The next talk, that is on augmented renal clearance. To talk on that, we have Dr. Mohammed Abdul Qadeer. He's a consultant critical care at Medicover Hospital, High Tech City. He won Best Paper Award in National Conference 2020. He won the quiz competition 2022. Multiple guest lectures he has given in state and national levels, part of several publications in national and international journals. With that brief introduction, I will ask Dr. Qadeer to continue with this.
Good afternoon, everyone. Thank you, sir, for the introduction. Uh, my topic for today's discussion is augmented renal clearance. As you all know, the topic name itself shows there is augmentation of the renal function. So, in my next few slides, I'll be discussing how our kidney will have improved or increased renal function based on various clinical scenarios. So, to start with the topic, I'll start with a case discussion. A 42-year-old man underwent a procedure for perforated diverticulitis. Afterwards, he had been treated with intravenous ceftriaxone 2 grams and metronidazole for 5 days. 6th day after the procedure, he became septic and CT scan was done, which was showing confirmation of anastomotic leak. So he underwent an emergency laparotomy and blood cultures and fluid cultures were sent, which was positive for Enterococcus faecium. He was started on intravenous continuous infusion of vancomycin at a dose of 3000 mg for 24 hours after a loading dose of 20 mg per kg. Despite the dose was increased to 3.5 grams per 24 hours, vancomycin concentrations remained subtherapeutic level at 17 to 25 mg per ml during the continuous infusion at day 2 and 3 from the start of treatment, and blood culture still remained positive. So what exactly we think at this point of time? See, the patient has been started with a dose of antibiotics and he was initially operated for some procedure, and later on he instead of improving, his trend became like a downward trend and he started getting infection and all. Antibiotics were optimized and still he was deteriorating. So what is the clinical condition we are thinking of in this condition? So exactly at this point of time, what we think is augmented renal clearance, what we think of clinical condition in this patient. Because of the excessive excretion of creatinine, clearance goes up and the drug levels gets excretion, elimination occurs faster, and lower dose of subtherapeutic dose of medications can cause sepsis in this clinical subset of patients. So what is ARC, how it is defined, and what are the patients who are being more prone to get a augmented renal clearance? So augmented renal clearance is defined as enhanced elimination or renal elimination of circulating solutes compared to the baseline. Augmented renal clearance is like when normal renal clearance more than 130 ml per minute per 1.73 meter per square is considered as, like more than that is considered as augmented renal clearance. In females, it is 150 ml per minute, more than 1.7, and in males, it is 160. So many studies have showed that 20 to 65% of critically ill patients have this condition called as augmented renal clearance. It is more common in young patients. Patients with traumatic brain injury has a highest incidence of 85%, subarachnoid hemorrhage more, and even in burns patient. Initially, this augmented renal clearance was started 40 years ago when it was studied in treatment of burns patient. Tobramycin was given, and they could not attain therapeutic dosing levels. So as I discussed in the previous slide, younger age, polytrauma, and less like not very sick patients, like moderately ill patients have a high incidence of augmented renal clearance. So again, other factors which contribute to is male sex, mechanical patients on mechanical ventilation, the patients who have increased cardiac index, on vasopressor use, all these contribute to your renal increase in the renal blood flow and leading to augmented renal clearance. So what exactly happens is the patients who are on like infection or any other trauma or any other conditions, they will have a systemic inflammatory response syndrome. So what does systemic inflammatory response syndrome causes? As we all know, any inflammatory response causes inflammatory mediators to release, cause vasodilation. These vasodilation also have an effect on the renal blood flow, increase in the renal blood flow, causing increase in the creatinine clearance. So increase in the cardiac output, fluid administration, vasopressor support, all these things contribute to your indirect increase in your renal blood flows. So finally leading to your augmented renal clearance. So why should we think of augmented renal clearance. So when a patient is sick, admitted in ICU, and you're not getting a therapeutic levels of drug, so proper drug monitoring, subtherapeutic doses can be deleterious or lethal to the patient and delay in the recovery of the patient. So how can we identify? We should do a creatinine clearance, or other prediction models are there which shows what exactly how you can identify augmented renal clearance and in which subset of patients. As I discussed, young patients, polytrauma patients, and patients with sepsis and all these patients are into high risk for augmented renal clearance. How can we modify our treatment strategies? We should do at regular intervals therapeutic drug monitoring, where a patient's your drug levels should be monitored and dosing should be adequately timed so that your drug levels maintain above the MIC for subsequent duration and prevents your early clearance. So as I said, there are two terminologies in it. One is augmentation. So how does augmentation happens and how does the clearance happen? Augmentation, as it is by systemic inflammatory response, which causes release of pro-inflammatory mediators from the body, and your renal function reserve. Every patient, as we discussed earlier in the previous slides, will have some renal function reserve. If your renal function reserve is good enough, as we discussed in pregnancy and all, the renal function reserve is less. So in patients with sepsis or any young patients, trauma patients, the renal function reserve will be more. So these patients are more prone again to develop this augmented renal clearance. So how do you calculate your renal clearance is by different methods. Cockcroft-Gault equation, modified diet in renal disease, and EGFR calculation with the chronic disease epidemiology. These are the different methods for calculation of your renal clearance. Increasing the augmentation, as I told, systemic inflammatory response is one of the major theory which explains your augmentation of your renal function. And renal function reserve, it depends on your different parameters like your capacity of the kidney to increase your like blood flow, which is usually seen in pregnant females, patients who are on high fluids, or patients on vasopressor support, or patients who are on medications or inotropic medications. It increases your cardiac output. So the diagram showing flow chart, systemic inflammatory response syndrome, which causes release of your inflammatory mediators, and in patients who are increase in the protein intake, protein load causes hyperdynamic circulation that causes your increase in the cardiac index. Renal blood flow will be increased on all the so indirectly your glomerular filtration rate will increase, which will contribute to your augmented renal clearance. And one more thing which we need not forget is organ crosstalk. In patients who are traumatic patients or traumatic brain injury patients, these elevated intracranial pressures, cerebral vascular dysfunction, or endothelial damage, these will have a brain kidney crosstalk, which is by release of your sympathetic hyperactivity, which impairs your autoregulation of the kidneys and altered baroreceptor reflex. All these things lead to your increase in the glomerular filtration rate, causing your augmented renal clearance. So there are different scoring systems to identify ARC. One is ARC scoring system, which has three factors in it: age 50, which denotes a 0.6, trauma 3 points, and SOFI score less than 4 is 1 point. So low risk patients are between 0 to 6, and high risk group patients are between 7 to 10. The other scoring system is Arctic scoring system that includes serum creatinine, male having a 2 points age less than 56 is 4 points, age between 56 to 75 is 3 points. Again, in this one, low risk group is between like less than 6 points, high risk group of patient is more than 6 points. Clinical treatments for ARS induced subtherapeutic drug concentrations. As I told, all our major antibiotics, we should know what the PK/PD of the drugs is, whether it is a time dependent elimination or a concentration dependent. Based on all those things, we can modify our administration of drugs. So should we go for a continuous level of infusion so that your drug concentration maintain above the MIC for a longer duration of time. So in this way, we can maintain, if the drug concentration is above the MIC for longer duration of time, time dependent killing will happen. So use the maximum approved dosing regimen. Better to use a continuous administration rather than intermittent drug administration. Therapeutic drug monitoring, and switch to an alternative agent that is not largely renally excretion. So other hepatic excretion methods, the drugs which are usually hepatic excretion is there, those antibiotics and all, we can switch to that methods. Some examples Like meropenem, when we use a bolus of 2 gram, because in augmented renal clearance, as we saw, the volume of distribution is more and the renal excretion happens. Septic patients, their volume of distribution is more. Even after you load a patient, because of the ARC, augmented renal clearance, the excretion happens faster. So in these patients, what we do is, and many trials have come up, Mercy trial, which has showed the continuous infusion of meropenem is much better than intermittent dosing. So vancomycin, again, a loading dose of 25 to 30 mg and a maintenance dose of 45 mg per kg per day as a continuous infusion, or it can be divided into 3 doses. And your therapeutic drug level monitoring should be to maintain a level of 10 to 20 milligram per liter. Piperacillin tazobactam, as we know that it is a QID dose, but if we give a continuous infusion extended over 4 hours, it helps in maintaining your drug level above your MIC. Levetiracetam, again, it is antiepileptic drugs that is have to be administered as a continuous infusion if at all you are thinking that your patient is having ARC. Levofloxacin, again, it has to be administered over 1 gram. It is a concentration dependent over 24 hourly. If we give, like if the as a bolus does also, if we give, the concentration of the drug is maintained above the MIC, so that will be useful in patients who are having ARC. This is a previous slide which I discussed, continuous infusion versus intermittent. Patient having ARC, if you give a continuous infusion of drugs, the concentration of drug is maintained for a higher time above the MIC, and there will be time dependent killing in the organisms. And this was proven by many articles published. One is Roberts et al. In 2016 and Barasa et al. In 2020. They showed that the PKPD of the drugs changes in ARC, so continuous infusion is much better than your intermittent dosing. And again, if a patient who is having renal clearance, which is caused by increased ARC, cause a further excretion of drugs, if we add a combination therapy to it, the therapeutic concentration of the drug is maintained, and it may have a proper dosing, and the in the time dependent or concentration dependent killing happen much better, and effective clearance of the organism and clinical improvement of the patient. So as I told, how we monitor is the TDM monitoring is best, and we need to understand the safety of the drug, PKPD of the medication, and to assess if we increase the dosing to a like maximal level, what effects or side effects will be having on the patient. There are different newer methods to analyze the ARC, which are known as multi-omic technologies, which are metabolomics, proteomics, genomics, and lipidomics. These helps in understanding the pathogenesis of our patients who are having ARC. So to conclude, what we need to understand is simple and accurate methods to determine and define ARC, and the duration and transient or permanent expression we need to understand. The mechanism of ARC is complex and it is not clear, and exactly to know the renal clearance is very difficult. So how we can optimize our patient is based on your therapeutic drug monitoring and administration of medications like continuous infusion versus intermittent. If we go through that, continuous infusion is helpful in such patient tiding over the crisis and facing the big challenges. As I told, newer techniques have been told to know what exactly happens in patients who are undergoing this, who are having are more prone for augmented renal clearance. Multimodal approach of biomics is useful in analyzing the patients with ARC. Thank you.
Thank you, Dr. Qadeer, and thank you for finishing it before your allocated time. So,